So I'm gonna start with a case right away. This was a couple of years ago. There was a patient admitted to our hospital coming through the emergency department with dyspnea, shortness of breath. And he got laboratory testing. The D-dimer level was high. So a pulmonary angiography with CT was performed. And there was this huge pulmonary embolism on both sides with central clots. This is how it looked like, even with saddle PE. And this patient, unfortunately, during that time, we did not offer any pulmonary embolism thrombectomy. He was put on anticoagulants, was admitted to the intermediate care unit. And during the same night, he was coded. And unfortunately, he died from his pulmonary embolism. And this is how the scan looked like. There was a RV to LV ratio showing severe right heart congestion. That's the different case. That was the first case. And the next case is a little later. That was like 2 years ago. Another central pulmonary embolism on both sides with saddle PE. Also here we had severe right heart failure, and we did a pulmonary embolism thrombectomy with the Inari system. And that way, with the 24 French flow retriever catheter, it was possible to retrieve the thrombi and to remove most of the clots from the pulmonary circulation. And this patient then did very, very fine. So first, I would like to show you the device we are working with and some specials of that device that helps to retrieve large clot out of the pulmonary arterial circulation. There were systems like, I don't remember the name, but smaller catheters that were used in the past to try to do pulmonary embolism thrombectomy, but this was most of the time unsuccessful due to the small size of the catheter, and there was not enough suction to get these large thrombi out. So with this Inari system, we have a very large bore mechanical thrombectomy device, 24 French, which can be used to declot the pulmonary circulation very effectively. It also comes with this nitinol discs that we at our center only use like rarely. Most of the time, the flow retriever works very well, and it's not necessary to use the nitinol discs. Sometimes it can help to get to loosen a little bit of clot in the pulmonary arteries, but most of the time the flow retriever is fine. So actually the Inari system is a large bore catheter which is used to aspirate thrombus from the pulmonary circulation. There's different sizes. Most of the time we go for the big flow retriever catheter, 24 French. Then we also have a 20 French curved catheter, which can be very useful on the left side if the angle of the pulmonary artery going to the lower lobe is quite steep. Sometimes the 24 French catheter is not able to follow down. So that's when we also use the 20 French curved catheter, which can be used coaxial through the 24 French catheter. So we can leave the 24 French catheter in the pulmonary main trunk and then use the curved catheter to go down on the left side down the curve to aspirate thrombus. Also, the flow retriever catheter with the nitinol discs comes in different sizes. So depending on the size of the vessel, different sizes can be used. But as I already said, most of the time we just work with the flow retriever. It's pretty rare to use the discs. So here's a small video from the company producing these catheters that shows how these catheters work. So basically there's clots in the pulmonary circulation. Then the catheter is advanced through a stiff wire. I will show the material that we need for that, but it's very flexible catheter. So even though it's a large bore catheter, it's very flexible and it navigates quite well into the pulmonary circulation, and it has this large bore connection for a 60 cc syringe, which is also able to lock for a nice aspiration, and the nitinol discs, which are also available. So then, after advancing the flow retriever catheter into the pulmonary circulation through the groin, a wire is placed, we advance into the pulmonary artery. I will talk about that a little bit later. Then the catheter is moved into the pulmonary circulation. The introducer is removed. The syringe can be connected. First, the stopcock is closed. We can lock the syringe and then open the stopcock that allows immediate suction, and therefore the clot can be retrieved from the pulmonary circulation. This is how it looks like in principle. Sometimes the nitinol discs can also be used, but as I said before, most of the time, if it's like a quite recent thrombus, it's perfectly fine to just use the flow retriever. It's usually enough. All right, so this is how this can look like. That's an image from Fabi Lage-Gaub, one of his signature cases where he went into the pulmonary circulation and declotted the lung. Now I have some more cases from our center where we did pulmonary artery thrombectomy, where we also got large amounts of clot out of the pulmonary artery circulation. As you can see, also here we have severe right heart dilatation. So that means that's beginning right heart decompensation and also congestion into the liver veins. Huge amount of clot in the pulmonary artery, in the pulmonary arteries on both sides. And here again, we entered with the 24 French flow retriever catheter and retrieved quite a lot of thrombus, and this helps the patient immediately on the table usually. So this is how the thrombi looked like. And this is some background on pulmonary embolism. The incidence is quite high. It's the third leading cause of cardiovascular death after myocardial infarction and stroke. So annually, it's around 8,300 deaths due to PE in the United States. And in high-risk patients, it can be up to 15%, no, in 40% in high-risk patients, up to 15% in intermediate high-risk patients in 90 days. Unfortunately, there was no clear evidence from randomized controlled trials for thrombectomy for over 10 years. So the first randomized controlled trial comparing two interventional therapy strategies was the Peerless study, and I will show some results of the study in the following slides. That was for intermediate high-risk pulmonary embolism patients. So why do these patients die, or what's the pathophysiology behind that? So usually if you have clots in the lung, that leads to an increased right ventricular afterload because of the clotting. That in turn leads to right ventricular dilatation, tricuspid valve insufficiency. The right ventricular wall tension is higher than normal. This causes more myocardial oxygen demand. And in total, that leads to obstructive shock due to heart failure and therefore hypotension in these patients. So when we have a patient suspected for PE, these are the guidelines from the European Society of Cardiology. It's a little bit outdated from 2019. But usually it's advised to do age-adjusted D-dimer values if PE is suspected, and if this is performed, then the question arises, which pulmonary embolism is of high risk, which is of intermediate risk, and which is of low risk. So there are some parameter that are telling us it's a high risk or intermediate high risk pulmonary embolism. So of course, if there is hemodynamic instability, we have a high risk pulmonary embolism. For the intermediate high-risk pulmonary embolism, some other clinical parameters are looked at, for example, the PESI score, the right ventricular dysfunction on echo or on CTPA. So if we look at the right ventricle, is it dilated compared to the left ventricle? Is there right heart failure? And we look at the cardiac troponin levels, which also tells us if there is right heart failure or like how do you say, not yet failure, but on the way to right heart failure. So low risk is if we don't have a right heart dysfunction, and if the patient is hemodynamically stable and doing okay. These patients usually are only put on anticoagulation. So to date, in the European guidelines, there's only weak recommendation for pulmonary embolism thrombectomy. So in high-risk patients, it can be considered. In intermediate risk patients, it can be considered, but there can also be anticoagulation, the strategy for treatment. If there is a high-risk situation and the patient is hemodynamically unstable, usually these patients still get systemic lysis at our university center and in most of the centers in Germany. It's now arising that we start to do thrombectomy for these patients, and we just started to enroll patients for the Persevere study, which is evaluating exactly these high-risk patients for thrombectomy compared to different other strategies. So new data is suggestive of very good outcomes in PE thrombectomy for intermediate high-risk patients, but also for high-risk patients. I will show some data on that. There was the FLAME study and the FLASH registry, all showing that the pulmonary embolism thrombectomy works quite well. So all of these patients get anticoagulation as first measurement to treat the pulmonary embolism. They get therapeutic anticoagulation. It has been shown that direct oral anticoagulants are non-inferior to unfractionated heparin through infusion pump or low molecular weight heparin. Nonetheless, if they present to the emergency department, usually we start them at first with unfractionated heparin through infusion pump because it's easy to adjust the values. So we can measure the prothrombin time and know if the patient is anticoagulated completely correctly. And if we want to do intervention, we can also pause it for a moment if we need to, or if there is some other problems such as intracranial hemorrhage. Sometimes patients present with intracranial hemorrhage and pulmonary embolism at the same time. In these cases, it might be necessary to lower the amount of anticoagulants in order to avoid progressive hemorrhage in the brain. In high-risk patients, systemic thrombolysis is still performed at our center, but this has high complication rates. So in the literature, it's 9.9% of severe bleeding events in these patients, 1.7% of intracranial bleeding, and a high dose of thrombolytics, usually 100 milligrams of RTPA is administered in 2 hours, which is a quite high dose and can lead to severe bleeding events. So first, I would like to show some data of the FLASH registry. Their patients were recruited in 50 centers in the United States, 800 patients, and the primary endpoint was a composite of major adverse events within 48 hours. So it was the safety of this treatment, so device-related mortality, major bleeding, intraprocedural device or procedure-associated adverse events. And here it was shown that I'll go through the results in the next slide. So first, these were most of these patients were intermediate high-risk patients, so 77%. Some intermediate low-risk patients, a couple of high-risk patients, and some intermediate risk patients were like the sub division into intermediate high or intermediate low risk was not done. So actually, the results from the study showed that there was an immediate mean PA pressure reduction after thrombectomy. here from 33 millimeters of mercury to 25 millimeters of mercury. There was an increase in cardiac index. The pulmonary vascular resistance was reduced significantly, and also the heart rate was reduced significantly directly after thrombectomy. The results were very nice. So if you look at this slide, which is summarizing all the results, you can see that it was a very effective therapy. 30-day mortality and readmission was very low. So all-cause mortality was 0.8% in this population with severely sick patients. All-cause readmission was 6.2%. So quite a good outcome. No device-related serious adverse events in this cohort. So in total, very nice results for this population, very safe treatment. So this is once again showing the safety. So 11 major bleeds, but in these studies, you have to know that the flow saver was not used. So now Inari has this flow saver where you can the blood that you aspirate during the maneuvers of thrombus aspiration, you can give it back to the patient. During that time, it was not used for all cases, and sometimes the bleeding cases are just a drop of hemoglobin because of multiple aspiration procedures. And 3 intraprocedural AEs. One was cardiac injury due to ECMO, which was not device related. Then a hypotension in a patient with extraperitoneal hematoma, also not device related. And 1 tricuspid regurgitation, which was incidentally noted 2 months after the procedure. So the relationship to the device is not 100% known for this case. But in total, it's a very, very safe procedure, and it helps a lot for these patients. So also the hospitalization was quite short. Only 62% did not have an overnight ICU stay after the procedure. So this is also quite nice, good results, and the very low 30-day mortality. So now there was also the Peerless study, which is a prospective trial comparing large bore mechanical thrombectomy with other interventional strategies to declot in pulmonary embolism. So this was a study to show that FlowTriever is superior to catheter-directed lysis therapy. I will show some data on that as well. So that's a prospective multi-center randomized trial. Patients were randomized 1-to-1. Intermediate risk pulmonary embolism patients were included in the study. The patients had no contraindication to thrombolysis because it was thrombolytics were used in these patients if they were randomized in the catheter-directed thrombolysis arm of the study. The primary endpoints were a win ratio composite at discharge, all-cause mortality, intracranial bleeding, major bleeding, clinical deterioration or bailout, or ICU admission and ICU length of stay. Follow-up was 30 days. So in the end, there were 274 patients in the FlowTriever arm and 276 patients in the catheter-directed thrombolysis arm. And here is the baseline characteristics. So in total, these are patients with low bleeding risks, relative contraindication to lytics in about 4% in the CDT arm and 4.4% in the FlowTriever arm. Of course, no absolute contraindications to lytics because these patients were randomized and received lytics. These were patients with low bleeding risk. That's how the patients were treated in catheter-directed lysis. It was not a uniform procedure throughout the centers, but different systems could be used. So echoes was used in some centers, Craig-McNamara catheters were used in some centers, some other devices for the catheter-directed thrombolysis. And this was compared to large bore thrombectomy, which was performed with the Inari system only with FlowTriever. So if you look at the device time in minutes, you see that the FlowTriever procedure is much faster than catheter-directed thrombolysis. The estimated blood loss during the procedure is higher for FlowTriever. That's because of the aspiration maneuvers where you always also have some loss of blood. But if you use the flow saver and you give the blood back to the patient, this is still quite not a large amount of blood, so shouldn't be a problem for the patient. So then there was the estimated residual thrombus in percentage that was lower on the FlowTriever arm compared to the catheter-directed thrombolysis. These are the TPA infusion rates per lung and also the dose per patient in milligrams. So about 16 milligrams as dose per patient was used for the catheter-directed thrombolysis. So if we look at the primary endpoint, which was the composite hierarchical win ratio of all these stated values, there was, I will show that there was a benefit for the thrombectomy patients. We look at secondary endpoints. These were functional outcome, length of hospitalization, and 30-day rehospitalization rate. Also here, we had significant results in favor of the mechanical thrombectomy. So if we here look at the primary endpoint, there was a clear favor towards the FlowTriever treatment. This was basically due to less clinical deterioration and or escalation to bailout therapy. So this was necessary in 5.4% of patients in the catheter-directed thrombolysis therapy arm, and only in 1.8% of FlowTriever patients. This would be, for example, placement on ECMO therapy. And also the post-procedural ICU admission, it was less often necessary for the FlowTriever patients, and also the length of stay on ICU was shorter in the patients treated with the mechanical thrombectomy device. So in patients with clinical deterioration or escalation to bailout, we had cardiac arrest in 2 patients in the catheter-directed thrombolysis arm, 0 cases in the mechanical thrombectomy arm. We had high-grade atrioventricular block in 1 case in the CDT arm. We had respiratory failure in 3 cases. So basically, you can see that really favors a FlowTriever treatment compared to the catheter-directed thrombolysis. If we look at escalation to bailout, there were 6 patients who needed a bailout strategy in the catheter-directed thrombolysis arm, and only 1 patient in the FlowTriever arm. So these results were significantly in favor of mechanical thrombectomy. And here, if we look at the clinical scores after the treatment, you can see that the dyspnea is better after mechanical thrombectomy. The right ventricular function is better after mechanical thrombectomy. Respiratory rate is better after, is improving more after the thrombectomy with a large bore catheter, and therefore the results are quite interesting. Here we can see that also transfusions administered were more often used in catheter-directed thrombolysis patients compared to the FlowTriever. There was some hemoglobin drop in both cohorts or in both study arms. This could also be explained by the loss of blood during the procedure, at least in part. So in total, there was a longer hospital stay for patients treated with catheter-directed thrombolysis, and also the longer post-procedure ICU admission. And the 30-day all-cause readmission rate was also higher for patients treated with catheter-directed thrombolysis compared to the mechanical thrombectomy. So this is clearly in favor of the mechanical thrombectomy. And here we see also the safety of FlowTriever. There was a very safe procedure, and all-cause mortality was 0.4%. So even though these were patients with intermediate high-risk pulmonary embolism, we had a very low all-cause mortality. And less than 90 milliliter estimated blood loss for the procedure. This was published in Circulation. It's a very nice study. And now we are looking for the next study, which is Peerless 2, comparing FlowTriever thrombectomy with anticoagulation only in intermediate risk patients. And our center is also contributing to the study. We recruited 14 patients at LMU Munich and randomized for either anticoagulation only or for mechanical thrombectomy. And I'm really excited how the results are going to be once we have all the data collected. So what materials do we use for the procedure? Now I would like to go a little bit through the material which is used. I already saw we have, I think, 2 or 3 FlowTriever catheter here. We have a sheath here. So basically we would have the equipment here at MNH to perform a pulmonary embolism thrombectomy. So we use local anesthesia, of course, at the groin. For access, we access with an 18 gauge needle. We use a 035 wire with a J-tip. For sheath insertion, usually we use a nice stiff wire to be sure that these large bore sheaths and catheters can be advanced safely. So we use Amplatz super stiff to get these sheaths and catheters in. Then we use an angled pigtail catheter to maneuver through the tricuspid valve in order to avoid any damage to the tendons, to the chorea. Then after accessing the right ventricle and tilting up into the pulmonary main trunk, then we go in with a glide wire. We advance the pigtail catheter, and then we change for a Amplatz super stiff wire to be sure that we can safely advance the FlowTriever catheter into the pulmonary artery circulation. Sometimes long, for example, Kumpe catheter or vertebral catheter can be used to navigate in the pulmonary vasculature once the FlowTriever is already present. We use a 24 French sheath, either Inari sheath or Gore sheath, but the Inari sheath has the advantage that you can also do an aspiration of the sheath. If sometimes you have like a clot sticking to the FlowTriever catheter, lollipopping, then you can pull it into the sheath, you can aspirate the sheath, and sometimes this helps to get the bigger clot declotted safely into the catheter or into the sheath. There's these aspiration syringes that can be locked with 60 cc. That's very good to have, so we get a nice negative pressure when opening the stopcock to have a nice suction of the clots into the catheters. So a blood saver should be used if available in order to avoid hemoglobin drop and blood loss if we need multiple aspiration maneuvers to declot. And we use a suture for closure. Some colleagues from cardiology use ProGlide system. That's also feasible, but I usually just do purse string suture. So here you can see another case from our hospital where we see large pulmonary embolism on both sides with massive thrombus with saddle PE. And we did pulmonary artery declotting with the Inari FlowTriever system. You can see the Amplatz wire stays in place. It's a short-tipped Amplatz wire in this case to have a nice stability. We advance the FlowTriever catheter, and then we can aspirate quite a lot of thrombus and get some nice results with declotting and immediate improvement of the patient in the table. This was one case where the radio-opaque marker of the FlowTriever catheter came off the catheter during the procedure. So it was still on the Amplatz wire, and with one suction maneuver, I could aspirate this radio-opaque marker. That just happened. I sent this to Inari to have a closer look what's happening there, what was happening there. What are potential complications that can happen during these procedures? So first of all, when you go up into the pulmonary artery, there can be arrhythmia during navigation. Sometimes it's a good thing to retract the wire and the angled pigtail if arrhythmia occurs, because sometimes it can be even hemodynamically relevant. The anesthesiologists sometimes say, oh, the blood pressure is now really dropping. We have a ventricular tachycardia. In these cases, sometimes it's good to go back and start from scratch when the rhythm has normalized again. So sometimes some parts of the thrombus might embolize into the periphery. This can lead to a temporary increase in pulmonary vascular resistance and to a temporary deterioration of the patient, but usually this is just temporary, and after declotting it gets better again. There can be injury to the pulmonary arteries. I've not experienced any injuries at our center, but there are some cases described where there was injury to pulmonary arteries. In these cases, like I had one Inari event where cases were presented. Sometimes a balloon can be used, can be inflated and inserted into the injured pulmonary artery, just block the flow to this side, wait for some minutes, and usually it's a low pressure circulation, so usually it closes on its own. So there are some bailout strategies. Perforation of major vessels of the heart, severe bleeding, pericardial tamponade can happen, but I've never seen something like that during a FlowTriever case. So what are the next steps at MNH? We already said the equipment is here. We could go for it. So we should actually go to the emergency department, tell them if there is a large PE, we would be capable to do declotting. So we could bring the patient to the interventional radiology department, to the angiography unit, and the team could do a FlowTriever catheter intervention to remove the clot. So now I would like to show one case. Have a close look to the initial CT scan. Is the patient a good candidate for PE thrombectomy? Then have a close look what you can see, if there's any unusual findings on the images, and then also the question, would you proceed with thrombectomy in this case or not? So this is the first image. It's a CT image, is a maximum intensity projection with clots in both pulmonary arteries in the central parts. Do you think this would be a patient who could be a candidate for mechanical thrombectomy? Maybe. What would you be looking for? Exactly, the clinical history, and also like how is the right ventricle, right? So you would like to have an echo maybe, or a CT scan, and have a look at the RV to LV ratio if there is any right heart congestive failure. Then we decided to go in and do a pulmonary artery thrombectomy. And this is the next image. What can you see here? What's happening? Do you have an idea? Yeah, say that again. Yeah, that's the aorta and the left ventricle, right? So actually there was a defect, I guess it's even a ventricular septum defect or atrial septum defect, I don't know for sure, but somehow with the catheter we went into the left ventricle, so there was either PFO or a ventricular septum defect, and as I used some contrast because it looked very unusual, I could see the filling of the left ventricle and of the aorta. So in this patient, would you go on with thrombectomy or not? What do you think?
No.
Why not?
It could be such as the system wasn't strong.
Yeah, I had the same feeling actually, and I did not do the thrombectomy. But when I was at the Inari meeting, there was a lot of discussion of these cases as well. And most said you can go on with thrombectomy. You could even leave the catheter there, use a second catheter to make sure you're not in the same way, but going the right direction into the pulmonary artery, and then do the declotting, because like it was said, like if you reduce the pulmonary artery pressure with the thrombectomy, you also reduce the risk actually of having a right to left shunt, which can cause stroke. So basically, if you do the thrombectomy, that's what the opinion was during this meeting. You should go on with thrombectomy in these cases as well, because you reduce the right ventricular pressure, you reduce the risk of right to left shunt, and you can still go on with declotting. So I think in the future I would give it a try and would declot anyways, but I think there is no clear evidence telling you you should do it or you should not do it. But at the Inari meeting, the discussion was like in favor of proceeding with pulmonary artery thrombectomy in order to lower the pressure in the right system and to declot the lung. All right, here actually you can even see, yeah, it was a persisting a PFO in this case, because on the CT scan, if you look closely, you can see that there's some contrast also filling from right to left actually, yeah. All right, so the next this is the topic, pulmonary artery thrombectomy. So I think we could go on with some questions for this topic, and then I would also talk a little bit about the management of pulmonary artery arteriovenous malformation, so HHT, and what we can do for these patients. So first of all, do you have any questions regarding the pulmonary artery thrombectomy topic? When are we going to do the first case? Soon. That sounds good. Yeah.
I was curious, did you guys, have you engaged with pulmonary, like the critical care ICU doctors yet about offering this procedure? Do they know about it? Or cardiologists?
Yeah, we talked to the emergency departments that was conveyed some staff.
Yeah.
They said they usually get them, but are we ready to do it anytime? The emergency, so it's like Eric wanted to set up some issues with the staff. Anytime we are called, we'll be ready for it.
Yeah, but sometimes,
Okay,
but in these cases, you can also like usually if it's like intermediate risk, you can postpone it like to the next day, just put them on anticoagulants and do the procedure the next day. If they are not hemodynamically unstable, you could go on with anticoagulation and do it on the next day. So in these cases, you don't necessarily have to have like a on-call service for that during the night, for example. So it would be feasible, I would say, to do it here at MNH. Yeah. All right. So then I would go on with the management of pulmonary AVM, hereditary hemorrhagic telangiectasia, because at our center we see these patients quite often because there is a ENT service for these patients, and they send the patients for bubble study, and then if there's some shunts, they get evaluation with CT scan with contrast with pulmonary arterial phase, and we would then take care of any pulmonary AVM if it is present. So that's the most common cause for pulmonary AVM is hereditary hemorrhagic telangiectasia. It's an autosomal dominant disease. The prevalence is 1 in 5,000. Prevalence of PAVM in these patients is 15 to 50%. So it varies, and it also has to do with the kind of mutation that is present, because there are different mutations that can cause HHT. The vascular malformations can also present with recurrent chronic bleeding, acute hemorrhage, complications from shunting, a bubble study where you use agitated saline for evaluating if there is bubbles going from the right to the left system after injection. It's very sensitive to look for shunts. The size of the right to left shunt determines also the degree of hypoxemia, and this also plays a role for increased ventilation and cardiac output. Complications can be stroke, hypoxemia with dyspnea, and abscess. So brain abscess is also a common problem if there's severe shunting through the pulmonary vasculature. So here we can see some studies looking at the diagnostic accuracy of testing for pulmonary AVMs in children with HHT. And there it was shown that the bubble study, the TTCE screening, is very effective, it's very sensitive. And if we find bubbles crossing to the other side, to the left side, then we might do a chest CT scan with contrast to look for further pulmonary AVM in the lung. This is another study looking at the treatment of pulmonary, like a table showing some studies looking at the treatment of pulmonary AVMs, and if there is shunts and pulmonary AVMs visible on CT, transcatheter embolization of these pulmonary AVMs is the way to go to reassure that there is no strokes happening and to lower risk of abscess and so on. So here we can see one case from our center where we have this quite large pulmonary AVM in the upper lobe with a nice feeding artery and a big draining vein. So basically what we do here, we advance a long sheath into the pulmonary vasculature after crossing with an angulated pigtail, putting a stiff wire in, then put the sheath in. And usually if you use a catheter which is quite a large inner diameter, you can place vascular plugs in this huge feeding arteries. So what you want to avoid, you don't want some material shunting to the other side. So shunting back through the vein and then possibly causing stroke. That's why we always oversize coils and plugs that we use in these cases and make sure they cannot flow through the AVM into the pulmonary vein, recirculate to the left atrium and then into the left circulation. We want to make sure that the material stays in place. So in this case, we used an AVP2 and a nice AVP, the AVP2 nicely closed this large feeding vessel. Then we used further AVP4 plugs to close the other vessels as well. And in the end, there was another feeding artery where we couldn't go in with a large catheter, so we used coils. In these cases, we used large detachable coils to make sure that they nicely form a nice dense coil packing in these pulmonary arteries to close the fistulas. So there was still some fistula present, so we placed one more AVP, and in the end we had a nice result. Sometimes it takes some time until it completely closes. So when you do the procedure, usually it's not clotting immediately completely, but the flow is reduced quite a lot, and we do follow-up scans on these patients after 3 months to see if it has resolved. You could also do bubble study, of course, and have a look if there's still bubbles going to the left circulation. Here's another case. We had this nicely visible feeding artery, this draining vein. Also here we placed a vascular plug. And in the end, we still had some other, so this patient was pre-treated on the right side, so there were already some coils in place, but there was still residual fistulas in the right lower lobe. So we also went there with a microcatheter and coiled these off. And in the end, it was quite a nice result and the fistulas were closed. So now I would go on with multiple choice questions, but first I would like to ask for some other questions regarding the pulmonary AVM topic. Yeah. Yeah. I think that's possible. I don't do it myself. This is done by our cardiology department. They do this transthoracic echo and looking at the bubbles. I think there is a way to quantify shunting as well. But if there is some significant shunting, we would always go for the CT angiography to look for bigger shunts on the CT scan. If the shunts are very small on CT scan, so less than 3 millimeter, the feeding vessel, then it's debatable if you have to close them or not. Some say it's not necessary if the feeding artery is below the diameter of 3 millimeters. But if it's easy to access, I would even close that. But sometimes it's also recurrent. So sometimes you treat patients, they come back after 4 years and they're new shunts. All right, so we could go on with the multiple choice questions. Which of the following complications in patients undergoing PE thrombectomy is least likely to occur? Arrhythmia, injury to heart and pulmonary vessels, transient deterioration of the right ventricular function, transient epistaxis, or oh, sorry, this is not. This one is this slide is not. I think it's not. Let's go on with the next one. I think I did a mistake here. Okay, so I have this one here. Which of the following complications are not associated with hereditary hemorrhagic telangiectasia? Brain abscess, stroke, atrial fibrillation, anemia, or epistaxis and nosebleeds?
Dr. Daniel, we can't see your screen anymore.
Oh, you can't see the screen anymore. Sorry. Let me. I'll share this again. Sorry. It's a bit slow. Let me. Where is it? Here. Can you see it now?
Yes, we can. Thank you very much.
Okay, perfect. So actually, I see it's the only question I have. I think I was not finished with the MC question. So that's the only one I got for you. Which one is the right answer? Atrial fibrillation is correct. But of course, it can happen with HHT patients, but it's not more often in HHT patients than in the usual population. What could be a problem if HHT patients have atrial fibrillation? What's the problem with these patients? What do they usually need and what's problematic in these patients?
They would need anticoagulation to prevent thrombus from forming in the atria.
Exactly.
Yeah.
And what's the problem with that in these patients?
They already have epistaxis and
exactly, the bleeding risk
as well. Yeah.
Exactly. So often they already present with anemia due to chronic bleeding, also chronic GI bleeding actually, because there are also vascular changes in the GI tract, and this also leads to significant GI bleeding and epistaxis. And in these patients, anticoagulation is often problematic. What could we offer these patients in these cases? If they have atrial fibrillation and ongoing bleeding, what could we offer them?
Cardioversion, mechanical cardioversion, maybe?
Cardioversion, yeah, but usually that's just temporary. Oftentimes they go back into AFib.
Then I'm not sure.
Sorry? Pacemaker? No, not really. Say it again. Yeah, you are talking about putting them on normal rhythm, either with medication or with an ablation procedure. That would be like one option, but this usually also requires ongoing anticoagulation. There's something else which we can do, which can help prevent stroke in these patients. It's now more the cardiologic question, actually. That's why I don't get responses. So closure of the left atrial appendage. So a device could be used to close the left atrial appendage, and this reduces the risk of stroke. So after the device is placed, they still need anticoagulation for a couple of months, but after that, if everything is closed, you can put them off the anticoagulation. That would be one option for these patients. All right, so that's my presentation, and yeah, I'm happy to take further questions, or if there is some discussion, I'm happy to answer questions. Otherwise, that's the presentation. Yeah. You had one here. You had a patient here with pulmonary AVM. Just discussion.
The discussion was with the pulmonary AVM, there's a risk for stroke and cerebral abscess.
Yes.
With interventions, during consulting the patient, we also warned the patient that this might occur. So that was a bit confusing. That the primary disease can cause the same problems which can occur during intervention.
During intervention, yeah, that's correct. But that's like, there is a risk during the intervention. It's a fistula between the right and left system, and you have to be really careful. And like, for example, air embolism should not occur in these patients. So if we have these cases, I'm like really very focused not to have any air bubbles in syringes and so on, like even more than usual, because this can cause stroke due to air embolism. But also, you're right, during the procedure, if you coil it, there can be a thrombus, and the thrombus could also migrate. I've never seen that during the intervention and after the intervention, but some of the patients we treated, they presented with stroke in the past because they had some subclinical DVT, and it just went all the way up and caused stroke. So this happens from time to time in these patients. But there is a certain risk, of course, and you also have to tell them during informed consent that there might be a migratory coil, for example, or whatever, causing a stroke. I've not seen this in these cases, but it's possible, definitely. Yeah, that's why we oversize our coils and plugs and make sure they don't migrate through. I remember one embolization of a fistula in the kidney that was after kidney iatrogenic biopsy-related kidney fistula, AV fistula. And there we used a pushable coil, and it went all the way through into the right heart and got stuck in the papillary muscle. We left it there and nothing happened. But in the Osler case, this would go through and would go into the left circulation and go maybe into direction of the brain, causing stroke. So this would be a severe problem.
Thank you for your question. I know in most AVM, our goal is usually to embolize the nidus,
yeah,
or the arterial end. For PAVM, is there any time we can consider embolizing from the venous end?
You know. So the access would be very difficult to the venous side, because this is left ventricle, like you would go into the left atrium and then into the pulmonary vein. I've never heard about that. And the next thing is, in these cases, it's fine to just close the feeding arteries. Because if you use, for example, liquid embolics, there is a high risk that it will go through and you will have migration into the left system, which you really want to avoid. That's why we use big plugs and coils to close them. Yeah, and not glue or onyx or something like that. I would be I wouldn't use that in the pulmonary artery circulation. I would say the risk for migration of liquid embolics is high. That's what I feel. I don't know if there's any data on that, but I think this is not usual to use liquid embolics in these cases. And dangerous. All right. Further questions from the virtual audience? So if there are no further questions, I would like to thank you for your attention and wish you a nice evening, or wherever you are, maybe a good morning. And yeah, thank you for joining in.